Thank you, Catherine, for this wonderful presentation. I'm kind of in a weird situation because yesterday Jordan already presented a part of the research I did, and Catherine presented another big part of the research I did. So that's why today I'm going to present actually the only research of my PhD which was not yet presented. So that's the research part of my presentation. And my research is also still like really clinically applied. It's really in line with what Catherine just presented. And that's why I've decided, because we're in a session about consciousness in brains and machines, to kind of do a little mental stretch and to apply some thought experiments also on the kind of research I did to kind of stretch it towards machine consciousness. So let's start with a little experiment or a little test. Are you conscious? If you hear me, please raise your hand. Okay, that's good. So that was just an easy demonstration of what Catherine just said. In many cases, if we're interacting with humans, then the behavioral response for us is enough to say, okay, you're conscious, you reply to my commands, you kind of heard what I said, you process it, and you raise your hand. So you're conscious and you're also highly responsive. But there are actually other cases, like in a deep sleep or anesthesia, you're neither responsive. So I also say like you're not conscious. But the interesting cases are actually the cases which are not directly on this diagonal, which are on the other extremes. So there are cases where you're not necessarily responsive. From outside, you seem like you're asleep or anesthetized, but you're actually dreaming. So you're having a rich conscious experience, really vivid experience. And in my research, I'm actually not looking at those physiological states of consciousness. I'm actually more looking at pathological state of consciousness. So how is this applied in the clinic? And there you have here on one end coma. This is really similar to your plot that you showed in the first slides, but it's kind of an abstraction of it. And on the other hand, you would have a locked-in syndrome where someone is completely unresponsive, but actually has a rich conscious experience, which we just don't have access to from outside. And then there's, of course, this whole area of fluctuating levels of consciousness and responsiveness, like sometimes there are some reactions, but not really, it's hard to interpret. We have unresponsive wakefulness syndrome and minimally conscious state. So this is still in line with what Catherine just said. And now the important part here is that most of what we do in clinics is actually, just like what I demonstrated at the beginning, raise your hand or squeeze my hand is what we usually do in the clinic. So mostly we assess consciousness on a response-based assessment. And what's mostly used is the Glasgow Coma Scale that Catherine just presented, and I also have a slide about it later. But what actually interests us is this dimension here. But how do we measure this? Like, what is consciousness actually? There are many researchers and philosophers who would say that there is many definitions of consciousness as there are conscious beings. And I do specifically say beings and not humans. So this is kind of a huge discussion point. But I think there's one definition, at least from my experience of hearing tons of different consciousness presentations, there's one definition which kind of gives the most common sense, which is defining consciousness through its absence. So consciousness is what you lose when you fall into a dreamless sleep. So this is kind of the common sense. We don't really know what it is, but we all know what it means to lose it. So what it is when you lose it. And Stephanie Bleimer's lab, the lab where I do my PhD in, actually took this idea to another level and transferred it to consciousness is what you lose when you're anesthetized. So this is actually a really smart idea to think about this common sense definition and to say, how can we just induce this? How do we do this in a clinical setting? And this is where we get to the NetIC protocol that Catherine presented in her presentation. And this is also the data that I'm going to present to you today, because I actually have results on this, which is now like soon getting published. So it's a data set of 42 patients who are in an intensive care unit. They also have a severe brain injury, and they're all in a pharmacologically induced coma. So what this actually means is they had an accident, in many cases like traffic accidents. They come to the intensive care unit. They are under anesthesia, continuous under anesthesia. And then, of course, the big question is like, will they wake up? Are they conscious? What is happening? So what the clinical team is doing is the so-called neurological wake-up test. So once a day, so the patient is completely unconscious because of anesthesia, but once a day, the clinical team, at least once a day, comes in, turns off the sedation, and does a behavioral assessment. So they turn off sedation, and in the best case, the patient opens the eyes, starts like talking, smiling, maybe even being aware of what happened, remembering their name. In the best case, this is what happens. And then the family can be like really optimistic about the progress of this patient. But in many cases, this is just not the case. And the response is either relatively minimal or there's no change in responsiveness at all. And that's a big problem. So this is just to remind you the figure that Catherine showed. We record EEG while the patient is on sedation, and then we continue recording while the patient is off sedation. And here I did an EEG analysis. So we did a high density EEG recording with 128 channels, and I specifically looked at features of power spectrum. So here, this is just like a caricature of power spectrum. Oh, you don't see power spectral density. So here we have a peak frequency that is changing. Here we have the spectral slope, which is changing. So the background activity of a PSD. Here we would have an offset, which is changing. So I looked at those kind of features in a really basic way to assess the brain response during this neurological wake-up test. So this is again the Glasgow Coma scale. So we have eye opening, verbal response, and the motor response. And I directly cross out here the verbal response because the patients I work with here are all intubated, which means even if they would like to, they don't have the ability to speak. So by default, they just rate 1 on this scale. But we still have the eye opening and the motor response. And here the motor response goes up to 6, which would be obeying commands like, do you hear me? Put your thumbs up, squeeze my hand, or squeezing your hand. So this would be kind of the ideal case. And this is what we actually observed in the clinic. So now every dot here is one patient, or every cross. They're marked by different etiologies, different types of brain injuries. And this is their responsiveness during sedation. So going from 3 being like not responsive at all, up to 11 being highly responsive. This is during sedation. You might wonder why there are patients highly responsive from sedation. There are some patients who had a really low dose of sedation, or patients who have like previous drug use, and that's where their body just tolerated sedation really well. So despite some sedation, they were still responsive to a certain level. But the interesting axis is actually the y-axis here, which is how much responsiveness they gained once returned off sedation. So now look at those cases here. Those are the cases which were completely unresponsive during sedation, then returned off sedation, and they went up to the highest level of responsiveness. So those are the ideal cases who wake up, who start responding yes or no, and they have a good prognosis. It's like good to see that. But then there are like different patients who have like those different good recoveries. So this is the group A, as I labeled them, the group with the good behavioral response. But there are actually other patients. This is the group B, patients who have like some or ambiguous behavioral response. So here they go from 3 completely unresponsive to like, let's say they gain 4 points, so they're somehow maybe eye-opening, but not able to follow commands. So the behavior is somehow changing, but not really in a convincing way, or still really hard to interpret clinically. And then there's the worst group. Here, the red group, so they start at different levels of responsiveness, or maybe eyes opening, or like different levels of GCS. But the thing is that they remain at this state, no matter where we have sedation on or off. They're behaviorally completely the same, which is a huge problem in the clinic as well. So the hypothesis of this study is that the first group, the green here, is that when we turn off sedation, when we see the brain like gaining responsiveness, the EEG should be changing. We should see something in the EEG being reflected to getting this increased awareness and responsiveness. And then for the red group, I actually expected to see that some patients to see the same brain features despite behavioral unresponsiveness. So I expected that within this red group, who is behaviorally extremely homogeneous, to see some differences in the brain response, so a more heterogeneous brain response in this group. And my third hypothesis is that this heterogeneous brain response has actually some prognostic value for these patients and could be used in a clinical way. So what I did is I used the brain response during sedation interruption of group A, and I used this to train a classifier, no, actually not a classifier, but a linear regression, to predict the behavioral waking up. So how much behavior they gained after I turned off sedation. And here it's just a linear regression, and I know we're on an AI conference, so you might say, okay, it's not really an AI, but for now it only had 42 patients. But in the future, I would expect to have like more powerful models, which can get like way more deeper features out of the high density EEG data. There's like way more potential to take out of here. We then validated this on group B. So it should still be able to kind of capture the response of group B, even though in the group B, there might be some patients where the behavior is actually underrepresented for the brain response. So here the question is like, how can we characterize the neurological aspect of waking up? And what we see, here's like the example of those patients who did really, really well, is that behavioral waking up is associated with spectral changes in the EEG. So this is here the moment when we turned off sedation, and you see it's like stays still a little bit at the same point, but then it starts changing. There's this massive change here that was like a minute, 2 minutes break in recording because we did an assessment. But you see that like there is definitely a dramatic change in the EEG, which is also reflected in behavior. We also see this in the flattening of the spectral exponent. So I showed you above, like before this figure with the aperiodic, with the EEG, and it's the background activity of the EEG, which is changing here. We also see this in increased relative alpha power. So those were kind of the most important features that the linear regression took to classify, to predict the level of responsiveness gain. But now comes actually an interesting part where we try to use this model on group C. And we looked at the brain response of those patients who remained completely unresponsive and tried to predict and anticipated waking up, which we didn't perceive in behavior. And this is what we see. So here you have the green dots is again the green group, yellow, they're kind of following the diagonal, so the linear regression works, but like more or less. But the interesting group is here the orange group. And in this orange group, you have some patients which kind of follow the line, but you have some patients where the algorithm would have predicted a really, really high behavioral response, but we didn't see it in the behavior. So this is one patient like this, where at this moment we interrupted sedation, the patient remained completely unresponsive, but look at the EEG, it changed completely. We really see a gradual transition once we turn off sedation, and the brain is approaching the state of a patient who just behaviorally woke up completely. So this is an interesting case, which could have like huge prognostic and diagnostic value to use this in a clinical setting. On the other end, this is a patient where the algorithm would have predicted like no real behavioral change. And again, we see the EEG is like just really static, no matter whether it's on or off sedation, it just doesn't change too much. So we kind of validated our first two hypotheses here. We see a brain response associated to waking up. And in those patients who behaviorally don't wake up, we still see differences in the brain response. But how about the third hypothesis? Like, does this have any value? So this is a plot where we have the outcomes. So red is red is non-survivors. Green are patients who actually survived their brain injury at least 3 months, but most of them actually a year. We have here the observed GCS. So what we've observed clinically, and you see that like there were many patients who had no good increase in GCS, and this figure alone is not really enough to distinguish, to differentiate between patients. So this is what we've observed in the clinic behaviorally. And this, in contrast, is the response that would have been predicted by the EEG. So we see it's not perfect, but we see it could definitely benefit a clinical decision. And by no means I will replace clinicians' judgments, but it could be at least a tool to give clinicians a different perspective into the brains of patients. So what we actually showed here is that EEG response to interruption of sedation has prognostic value for participants with absent or ambiguous behavioral response. So we have patients who are still unresponsive, but in their brain, it looks like they would have shown like some signs of waking up, at least cognitive signs of waking up. And this is actually interesting, and now comes the machine part, because in the community, we always only ask this question of humans. We look at computers and machines and we ask ourselves, are they conscious? Are all models conscious? But what actually happens in most of the clinical research is that we have machines and models who try to tell us whether humans are conscious, especially in those extreme cases of altered states of consciousness. So is this a valid test of consciousness? No, it's not. We usually talk about it as the brain's capacity to emerge and sustain consciousness. But just because I see behavior like neurological signs of waking up, I couldn't really tell you that those patients are actually conscious at the moment of reporting. So this is just as a kind of limitation of it. But at least here we see, I have kind of those two dimensions. And AI, I think at the moment, like most of the LLMs that we usually have, they're highly responsive, but I think at the moment they're like not really conscious. But the thing is that with AI, we kind of have the inverse problem, where for humans, pure responsiveness or unresponsiveness is not sufficient to say that they're unconscious. And for AI, high responsiveness is not sufficient to say that they're conscious. So most of the tests that we have are actually just like in humans based on responsiveness. We have the Turing test, we have the test that Catherine just mentioned, or even the test about theory of mind. AI needs to be able to reflect on someone else's cognition. Like they're all still behaviorally and response-based. So I think we would need another axis here that actually also quantifies consciousness in like more mechanistical way, just like I tried to show this in humans. Or also to just define background conditions to say, if the responsiveness is in a way that I would suspect consciousness, and we have those background conditions fulfilled, like the algorithm is able to learn, like to continue learning, the algorithm has a memory, the algorithm dynamically adapts and changes, then we would expect like a consciousness. But this is not my research, so it's a speculation, and I hope that it might be one day one of yours research. And why is this important? I still have a little thought experiment at the end. I still have 1 minute, so I think it's good to do it. Why is this important? Because I'm actually convinced that artificial consciousness is possible. I'm not saying that I'm convinced that it already exists. Therefore, I have a really nice little thought experiment that kind of I really liked. For those who already know it, you can still enjoy it. Okay, so imagine we're in the future. We're in the future, and we have developed a technology because we're brilliant neuro-AI scientists of artificial neurons. So now we are able of replacing a biological neuron by an artificial one. And those neurons are not just like dummies. They're actually, if you give the same input stimulus to the real and the artificial neuron, you exactly get the same output. I mean, those are just like electrical signals. So we really have managed to replace them perfectly. And now you're in the future, you have, you go into clinic and you let replace one of those neurons. So now you have one artificial neuron in your head, which is doing exactly the same job as the neuron that you replaced. Who of you would say that you're still conscious? Yeah, we already lost some, but okay. Okay, so one hypothesis, neuron might be already enough to lose consciousness for some. Okay, but for those who think they're still conscious, now let's say, okay, there you have like a little larger issue. We're replacing 20 neurons. Are you still conscious? Yeah, still many conscious people here. How about half of the brain?
Yes.
Remember, they're doing exactly the same job, and not just in general for neurons. We're really looking at every single neuron and rebuilding your artificial neuron into a copy of it. Okay? How about your whole brain?
Yes. Yes.
So still some conscious beings here, despite having replaced the whole brain by artificial neurons. And that's actually a place where, of course, we're technologically not at a place, but it's a thought experiment to kind of illustrate the point that consciousness does not necessarily rely on biological matter. It's an emergent property. It's a kind of information that arises from the organization and from the dynamical flow that happens inside your brain. But the fact that it's happening in neurons and in carbon-based, it's not a necessary condition, in my opinion. But that's why I said it's a thought experiment. And for those who are interested, there's actually an extension of this where you replace your whole brain. And this is like just out of interest, but there's an extension where you then distribute the whole neurons over the universe. But I won't go into this today. So, but I'm open to discussion for later. So, okay, so now we're back at Unix Student Symposium. Are you still conscious? If you're, then I thank you for your time. And I want to thank the Unix Student Symposium organizers.
Thanks, Sharon. So you can have one question. Or we have I have a question.
Yes.
Yeah, you showed us the EEG signal that quickly ramps back up with the that I guess like a clinician could look at this and say, oh, something's happening.
Yes.
Purely qualitatively. So like like 20 years ago, or for how long have
The thing is, EEG is used in a clinical setting, and clinical EEG is part of the assessment of every single of those patients, but it's not a continuous EEG and it's not paired with anesthesia. So they often have an EEG, but independent of the neurological wake-up test. And the key part here is to do them simultaneously. And this is something that is not part of the current clinical practice, but that's also this big advantage because EEG is available in clinical practice, anesthesia is available in clinical practice, like everything is there. They would just need to change the timing of it, and this has a huge potential for the assessment of those patients, and would be really easy to implement in like ICUs all over the world.
Yeah, because looking at this, you could have made some mistake, we probably just didn't be.
Yeah, it opens a different perspective, which should not be neglected.
Sorry, we don't have.
You can ask me later.
You can ask the questions.